Hi, Dr. John Brady. I'm an ICU doctor at Lawrence General, also a colonel with the New Hampshire Army National Guard. I'm going to give you a little primer on mechanical ventilation in case you have to manage a ventilator that you're not used to doing. We're just going to talk about a few things. We're going to talk about lung compliance, talk about some basic ventilators and what the settings might be, how you make adjustments, and what sorts of complications you need to look for and how to adjust them. All right, so the first thing I want to talk about is compliance. So compliance is going to be the change in volume over the change in pressure. This is really important to understand. There are two basic types of compliance when we talk about the lungs. We talk about the total compliance, which is the respiratory system compliance. Right? And respiratory system compliance is made up of the compliance of the lungs, but also compliance of the chest wall. And the chest wall also includes the abdomen. An example would be if somebody had an intra-abdominal catastrophe and ended up having a big operation, and then after the operation they have a lot of swelling. That swelling is going to push up on the diaphragm. It's going to impact the ability of the diaphragms to descend and for the lungs to expand. When we talk about lung compliance, there are two components. There's what's called dynamic and static. So when we look at changes in volume based on what the ventilator is giving and what the pressure is, that's going to be the overall respiratory system. But you need to understand that as air is flowing in, you're going to get a change in the pressure that's going to be based on both of these things. Dynamics compliance is really, we're talking about resistance. Where static compliance is really what the stiffness of the system is. Why is this important? It's important because dynamic compliance could be because someone has a lot of bronchospasm, or they have a lot of secretions in their airway, or they're biting on the tube. You need to try to recognize this. Static compliance could be because the chest wall is stiff, the diaphragms are pushing up, the lungs are severely injured and are now filling with fluid and are stiff, or they have pneumonia or pulmonary edema. All these things are going to cause stiffness in the lungs. So when we push air into the lungs with a ventilator, the pressure goes up and then we let it come out. So if I give, let's say, a 500 cc tidal volume, the pressure goes up. If I hold it and not let that air come out, that pressure is going to drop a little bit, and then I let it out. This is called my peak airway pressure. This is total respiratory system compliance. That's going to be made up of all of these things, and it's a dynamic compliance because the air is moving in at that time. So if I hold the ventilator breath and allow the air to continue to get past any obstruction, it'll come to a new plateau called my plateau pressure. That plateau pressure is reflecting my static compliance. All right? So that's going to tell me if my lungs are real stiff or if I have a lot of resistance. So another example would be I give the breath and I get this big breath pressure and I get a big drop. So my plateau pressure is low, but I have a high peak airway pressure. The difference between these two is reflecting my resistance. This tells me my lungs aren't very stiff. This is telling me that my resistance is really high due to airflow, obstruction, or resistance. So my patient may be wheezing really tight. They may have they may have secretions that are obstructing their airway. They may be biting on the tube. If I come back here and I have high peak airway pressure and a high plateau pressure, that's telling me my respiratory system is very, very stiff. And that could be for all those things: chest wall, abdominal. It could be that my lungs are super stiff. It could be now that I have a tension pneumothorax on one side over the other. All right? So it's important to understand compliance when you evaluate the ventilator, because we're pushing air into the body, and we have to understand what are the things that are going to make that pressure go up or come down. Okay. So let's talk about how do we decide a ventilator settings. Well, on an adult or a child, but basically we go by ideal body weight. An ideal body weight for a male is going to be 50 plus 2.3 times the number of inches greater than 5 feet. All right? So let's say I've got someone who's 5 feet 10 inches. My ideal body weight is going to be 2.3 times 10, or 23, plus 50, and that's going to give me a 73. Right? That's our ideal body weight. For a female, it's going to be 45 plus 2.3. Right? So if I have a female who's 5'6", right? Well, I should have picked a number. If it's 10, it would be the same thing, right? So it would be 23 plus 45, so that's going to be 68. Okay, so her ideal body weight would be 68. All right, so once you figure out what the ideal body weight is, most patients, your tidal volume that you're going to give is going to be based on that. And so most adults with relatively normal lungs, we're going to give between 6 to 10 mLs per kilogram of ideal body weight. All right, so if I have an 80 kilogram male and ideal body weight is 80 kilograms, the upper end is going to be 800 and the lower end is going to be 480. All right, so somewhere in that ballpark. So a good number might be 600. All right? Okay. So how do we pick the settings? There are a lot of different types of ventilators. There are many different ways to provide mechanical ventilation, but we're not going to talk about that. So this is apparently for people who you're dealing with a crisis, you don't have a lot of experience. Almost everybody that you're going to put on a ventilator is going to be on a basic volume-controlled ventilator. All right? And depending on the type of ventilator you have, if you have a portable ventilator, you're not going to have a lot of bells and whistles. So what you're going to do is you're going to set up the tidal volume times the respiratory rate, the FiO2, and then you're going to add what's called PEEP. Okay? Tidal volume we talked about, right? So based on ideal body weight, figure it out. And most people are going to have a minute ventilation, which is your tidal volume times respiratory rate. Most people are going to have a minute ventilation somewhere around 5 to 8 liters per minute. You have a sedated, normal patient who you're intubating because maybe they had a narcotic overdose. You don't need really much more than 4 or 5 liters per minute. If you have somebody who's got a lot of lung disease, it may require 8 to 10 liters per minute of ventilation because a small percentage of your ventilation is actually participating in gas exchange. But that you're going to have to assess. So you calculate your tidal volume, estimate what you think your minute ventilation should be based on the circumstances. Most people you're going to start off with either 100% or 90%. PEEP, which is really when I give a positive pressure breath and I allow it to come back down, this is my scale and this is 0. I don't let it come down to 0. I keep it up here somewhere, and usually around 5 or 10 centimeters of water. Okay, that's your PEEP. And what that's doing is it's basically keeping the lungs expanded at a higher volume than they would be if you didn't have PEEP. And it also helps with your oxygenation. We're not going to go into all that right now because this is just a basic talk. All right, so you're going to have them on volume control. Depending on the type of ventilator, it may be called assist control, but it's a volume control. Tidal volume times the respiratory rate. Pick the FiO2. If you're just intubating the patient, you can pick a high FiO2, like 90, 100%, and you're going to pick your PEEP. And usually somewhere between 5 to 10 centimeters of water based on the pathology. If you got somebody, let's say what we're talking about with COVID-19 who has diffuse bilateral airspace disease, you're going to pick a higher PEEP. You're going to pick somewhere around 10. All right. What kind of adjustments do we make? Well, let's say you started off with 500 times 10, 90%, and a PEEP of 5. And let's say when you set that up, your peak airway pressure is 40. Depending on the type of ventilator, you may not be able to detect what their plateau pressure is. You may have to paralyze this patient to really assess what they're doing, but you need to examine the patient. You need to look and see, is there air actually going into the patient? Sometimes when the airway pressure is real high, the machine will not deliver the breath. It'll just pop off. So you have to make sure that the patient's getting the breath. If they're getting the breath, then you have time to sort of figure it out. So you want to look and see, are they wheezing? Are they biting the tube? Is there a kink? Can you pass a catheter down through the tube? Do we have good breath sounds? Is the trachea midline? These are all the things you kind of want to look at. Is the stomach overdistended because you were ventilating that patient prior to intubation? Maybe you need to get an NG tube in and decompress their stomach. So that's the first thing you're really going to look at, is what is my airway pressure? So if you feel that the airway pressure is too high, because we really don't want it greater than 35. Okay, we don't want that. But if you have to, you tolerate it, but generally we want to try and keep it 35. You might have to drop the tidal volume. So drop the tidal volume to try to get your peak airway pressure down. Treat any bronchospasm aggressively. Make sure you don't have a tension pneumothorax. Make sure you don't have a distended stomach. Try to fix all the things that are affecting your airway pressure. Look at your pulse oximetry. Make sure you have a good pleth. If my pleth is 99%, you can start to come down on this. If you're not, if your pleth is telling you you're in the 80s, then you might have to start creeping up on the PEEP. Until you get the PEEP up, don't be afraid to go up to PEEPs at 16 or 18, and then gradually come down to FI2. Depending on the length of time you'll be managing the patient, if it's only short term, you're getting them from point A to point B, don't worry about it. Put them on 100%. Put them on 10 a PEEP. Just leave them there. Just do the best you can. But just look for complications of not ventilating the patient, all right? Okay. So the main complications you have to worry about are going to be things like a dislodged tube. Very important. Once that person's intubated, look and see where the endotracheal tube is. If it's marked at 23 and you're having problems, look and see where it is. Maybe it's not at 23 anymore. Maybe it's at 25 or 26. Maybe it's a right main stem bronchus intubation now. Make sure you don't have a pneumothorax. If you've got tracheal deviation, you have a patient who's hypotensive, you have high airway pressures and low volumes, you're not able to get the volumes in, you probably got a tension pneumothorax. Don't wait for a chest x-ray to get a needle decompressant on that whatever side. So if my trachea is deviated to the right, put a needle, mid-clavicular line, second intercostal space. Find angle of Louis, come over to the mid-clavicle, go down, hit the rib, go right above it. Okay, and then you have to proceed with a chest tube. All right, hypoxia, right? You can't oxygenate, so you're gonna have to make adjustments, right? You're gonna have to go up on your PEEP. You may have to treat your bronchospasm aggressively. All right, make sure you have oxygen. I can't tell you how many times I've seen the tank run out of oxygen, and if patient's desaturating, everybody's going crazy trying to figure it out. What happened was there's no oxygen in the tank. All right, so make sure you check that. And if you're able to, get an EVG. All right, and make adjustments based on the EVG. You might have to just call and talk to somebody. All right, but these are the things you want to make sure you look for. Okay, make sure the tube's where it's supposed to be. Make sure you don't have a pneumothorax. Obviously, the worst one, which I didn't mention, I'm assuming it's in the right place, is an esophageal intubation. Okay, that's devastating. So if you do that and you don't recognize it early, your patient's going to die. So if you do an intubation and you're not sure you got it into the trachea, just go back down with the laryngoscope, look and see. And if you're really, really not sure, just pull it out and bag the patient and then try again. Okay? All right, I'm going to do another YouTube video in another room with a portable ventilator and with a hospital ventilator just to kind of show you how we manipulate it. All right.